1 millimeter to several millimeters, generally call them as micro nodules. Okay, nodular pattern has got two types in them. They are the micro nodular pattern and the macro nodular pattern. But both of them generally looks down assortment of dots, right? You will also see them, and you have to also remember, if you can remember it from the last chapter, uh, if you can remember last time, what we were talking about is that any kind of a patchy opacity is showing down as the airspace disease, right? Or most of the lobular pneumonia, segmental pneumonias, all of them appear down as patchy opacities. But now what happens, the airspace lung diseases do not have a clear or well demarcated border, right? But here the difference is the nodules will have a well demarcated border. They are clear, you can clearly, visualize them, and you can also demarcate and look at the borders, that they have a regular border. They come down in different shapes. They can coming down as smaller dots, they can come down as circles, they can come down as bigger dots, something like this. So they have a well demarcated border. So such kind of pattern is actually called as nodular interstitial. Can somebody help him? Can somebody help him how to find that there? Monitor, there should be this. Okay. So, right. So, just wait. Unjoined. Okay. Okay. Now we will see here, and now the last one is something like this. If it is coming down as both, okay, if it is coming down as both, that is the dots and the lines together, we call it as the reticulonodular pattern. So we have three main important patterns in the interstitial lung disease. One is reticular or lines like opacities. The other one is nodular or dots like opacities. Then we have both lines and dots, which is combinedly called as the reticulonodular interstitial pattern. Okay, let us see at the images, you can understand. Now look at the image A, and you can see here, look at the image A. You see here, this is a small pattern of lines and lines and lines itself. You see here, you cannot separate this one line or the other line. You can see that they have been coming down as the extensions. Okay, now, so such kind of pattern over A is actually called as a reticular pattern. Okay, I will tell about the what are the pathologies actually, which actually cause such kind of patterns. But first try to image yourself how exactly they look like. All these one that looks like as the strong lines, the opacities that looks like as strong lines and diffusely distributed all over the chest fields are actually called as a reticular pattern, and they have a crisscrossing lines. And one of the best important example for this kind of reticular pattern is nothing but your sarcoidosis. Okay, sarcoidosis is one of the disease. So remember this example. What is the disease that will have a primary reticular pattern, which obviously indicates it is a interstitial lung disease, and sarcoidosis is one of the best example. Now The other image you see here on the image B, when you zoom in, you actually see here, this one actually appears down as small dots. Can you appreciate it here? You see here, these small dots where my mouse is moving on, here. So all of them, they doesn't look like the lines here. They obviously look like the smaller dots, which means to say these areas, certain areas along the interstitium have been accumulated together, and they are not fibrosing. Generally we can say that fibrosing is the characteristic feature of reticular pattern, and where are nodular things, this we actually call this nodularization as a term called as proliferation. Okay, proliferation, we call this as proliferation. And generally this may not be a common one, but still you can actually say it is actually happening. This kind of nodular pattern or the dotted pattern will usually happens in case of metastatic lung diseases. Okay, metastatic lung diseases. And you see here one of the common disease that actually comes down and metastasizes down into the lungs is thyroid carcinoma, ovarian cancers, and then bone cancers, right? Osteopathic cancer and ovarian cancers also invade down into the hematogenously and lymphatically spread down as a metastatic reaction and causes a reticular nodular pattern. Right. Okay, that is a very good question. Okay, somebody was asking how can we actually differentiate the reticular pattern and the pulmonary markings on a CXR. Now, you see here, look closely. Okay, look closely here. A pulmonary marking, okay, a pulmonary marking usually has to follow a pattern where all the bronchuses are going. It was a small anatomical fact that we know before. You still can't hear, guys? You still can't hear, guys? Can't hear? Right. Okay. See, what about Aman? Can you hear? Okay. The way how we usually, okay, I guess Benedict can hear, right? Okay. What about Didi? Can you hear now, Didi? Aman, can you hear now? Right. Okay. Okay. See, the way Aman was actually asking, how do we differentiate between the pulmonary markings and the reticular pattern? Okay. The first thing what we usually do in a reticular pattern, what we do, the first thing what we do here with a, pulmonary markings is that as a basic anatomical fact that every bronchus is accompanied with its corresponding pulmonary blood vessel, right? That as a fact. And the pulmonary bronchus diameter is almost equal to the pulmonary blood vessel diameter, which logically means to say both of them typically have the same diameter based on their location. For example, to say the right main bronchus has got almost equal diameter that is related down to the pulmonary artery or the pulmonary vein. And when I go down to secondary bronchus levels, when I go down to tertiary bronchiole levels, and then when I'm finally coming down to last in the alveolar tree, their branches, the diameter of the pulmonary vessels, their branches on the pulmonary vessels will be the same as the branches on the pulmonary vessels will be the same as will be the same as the reticulo. Sorry, it will be same as the pulmonary markings itself, right? Now, if you can look closely into this image, can you still see? Can still cannot see? Right. Okay. Now look here closely. This one actually the reticulum, the reticular pattern usually is not following a single direction. Well, let us say you see here when you follow the bronchial tree, the right main bronchus comes down into the periphery. They doesn't go in a randomized pattern. They go in a tree pattern, and it is well obvious that most of the bronchuses are not visible, right? But interstitium came to be visible right now. And if you look closely, the bronchus thinks the pulmonary markings do not crisscross each other. And whenever you have got a pulmonary marking, the close to that you can also find a preliminary shadow of the bronchus itself. But here in the reticulonodular pattern, sorry, in the reticular pattern, I cannot see such kind of a bronchus. Okay, let us say this is the bronchus. Bronchus technically looks a little bit of circular areas, you see here, but the opacity that is surrounding to that one is to not follow the same like a circular motion. It is actually looking down as the crisscross lines. So by this, actually, I can understand this is not a pulmonary marking, but indeed is a reticular marking. Aman, is this doubt clear now? I can differentiate the pulmonary markings with the reticular pattern just because I'm looking at the same shadows of the bronchuses. The bronchuses usually the accompany with the pulmonary blood vessels, and the diameter of the pulmonary blood vessel is almost equal to the bronchus present with it. But they show and they come together, they go together. But here you can see the bronchus here, and surrounding this opacity is actually having a more crisscross line, and this crisscross segregation is not seen within the pulmonary markings. So that is how I actually know if I'm looking at the pulmonary markings or if I'm looking at a reticular pattern. And most of the other things is that, okay, if it could have been a pulmonary marking, generally, the patient do not complain of a severe grade cough, and the person will also not have dyspnea, and they also do not have restricted chest movements. Okay, most of these patients with the interstitial lung diseases will present up with chronic symptomatic presentation, but if it is a pulmonary marking or if it is something that generally the patient do not have a specific pattern of a symptoms where you can associate into a particular disease like metastatic lung disease or particular disease like sarcoidosis. No, you cannot differentiate those symptoms. So clinically also they present differently, and also radiologically they have a specific imagery, right? So that is how you differentiate between a pulmonary marking and uh, a reticular pattern. Now when we look to this third image here, you see here, there are small dots. Okay, there are small dots. Can you appreciate the dots here? These are the small dots. And surrounding to that is a crisscrossing lines. You see here, crisscrossing lines, small dots, small dots. You see here, this is the bronchus. But close to it, you see here, this is the smaller dots. You see here, let us say this one, the bronchus is almost uh, visible here. This one, something should be, that one is actually going down as a vertical bronchus, right? That is actually passing down in the lower lobes, which is actually going down horizontally from posterior side and projecting down to the anterior side, right? And the other things here, what we actually see here, and close to this bronchus itself here, we got smaller opacities. And next, immediately close to it itself, also we have got, crisscrossings. So such kind of mixed pattern together, we call it as a reticulonodular pattern. Okay, reticulonodular pattern. And you have to understand one thing here. It is also called as intersecting, lacy network, and small nodules. So they have three differentiating feature, and this one is actually indicates such kind of a reticulonodular pattern, suggests that the patient has down progressed into a chronic condition. Okay, sarcoidosis, acute sarcoidosis, and chronic sarcoidosis. We generally say right if it is called as a reticulonodular pattern. Okay, so it is called as the reticulonodular pattern. Right. So the thing here you have to remember is that, okay, if it is looking down as lines, reticular pattern. If it is looking down as small dots, we call it as nodular pattern. And if it is looking down as the dots and lines together, we call it as a reticulonodular pattern. These are the three basic features that we actually appreciate it for a interstitial lung disease. Now you see here, Uh, yeah, the pathology that is related to the reticulonodular pattern is one of the specific examples of the most common type of disease that we actually see is, tuberculosis. Tuberculosis generally gives down to a reticulonodular pattern. Okay, when we come down, because in the last parts of these things, while we are trying to recognizing the patterns, yes, we have this examples. Okay, we will deal them there. Okay, don't worry. I will explain it in the next coming slides. All right. Now you see here, what you have to see here, you actually mention that these smaller particles or these smaller packets or the smaller lines are generally inhomogeneous. Inhomogeneous in the sense that they do not have a specific pattern itself. Okay, at some areas they might be darker, at some areas they might be lighter. For example, to say some areas could be more opaque and some areas can be more lucent. So such kind of a pattern is actually called as inhomogeneous pattern. Inhomogeneous pattern can also be called as a heterogeneous pattern. Okay, homogeneous pattern, heterogeneous pattern, or you call it as inhomogeneous pattern or heterogeneous pattern. There are two patterns. If it is looking, everything is looking equal. If you can remember last time how a pneumonia looks like, it looks like as a homogeneous density, right? All the area that the pneumonia has been covered, all the consolidated area is looking down white, equally white, right? But now this one is does not look like that. Even if this one has invaded down into a larger space of the lung, they do not look like a homogeneous pattern. They do not look equally white. They look different. Different areas are white and different areas are black, or let us say different areas are opaque and some areas are lucent. So such kind of pattern is actually called as inhomogeneous pattern, right? And then the margins are sharper. Remember, in pneumonias, we don't have a well-distinct margin, but in interstitial lung diseases, yes, they have a well-defined margin, right? And the boundaries tend to be is indistinct. Airspace diseases has got the boundary, indistinctive boundary, whereas the interstitial lung disease has got a distinct boundary. Margin is well demarcated in interstitial lung disease, where the margins of the airspace diseases are not well demarcated, right? Okay. Then the interstitial lung diseases can be of two types. They can be focal in the sense they are coming down in a smaller area, okay, or they can be diffuse, they can be generalized, they can be present in unilaterally, they can also be present bilaterally. It means to say either present in one lung or present in two lungs. They can be present in a small part of a lobe, or they can involve entire lobe, they can involve entire segment, they can involve entire lung. So that is how different patterns. You can actually mix up a lot of patterns: unilateral, bilateral, segmental, intersegmental. Okay, or interlobar or complete hemithorax. Hemithorax in the sense one side. So they have so many patterns here. Now, this is what I have been talking about before. What, remember here, you have to remember a very typical definition. It's called as what is a solitary pulmonary nodule. Remember, solitary pulmonary nodule. It is also called as SPN. Okay, SPN. SPN is nothing but a solitary pulmonary nodule. Solitary pulmonary nodule means to say, can everybody see the blackboard? Right. See, let us imagine here, this is the lung. Solitary pulmonary nodule, before I was talking about the definition, any kind of an opacity that is greater than 3 centimeter is called as a mass. Any kind of an opacity that is to 1 centimeter or greater than 1 centimeter, 1.5, you can usually say, it is actually called as a nodule. Okay, and several okay, this is several mm. Now 1 to almost 6 diameter, you call them as micro nodules. Now you have to remember here one thing. You cannot see it. Okay, now what you actually have to remember here, if this kind of a nodule, okay, if this kind of a nodule is present as a single one, okay, it's present down as a single one. Yashiraj, if you are unable to follow it, you just try to open down the slides. I'm just going down through the same theoretical slides what we have been posted in the rain classroom. Okay, I am recording the session. Okay, if there is some kind of a technical difficulty for you guys, maybe I think you have to give it time to get a little buffer. Okay, right, right. You see here now, if this kind of a opacity is present as a single one, it is called as a solitary pulmonary nodule. Only a single one. Okay, SPN is a nodule. Okay, SPN is a opacity, a nodular opacity that is present as a single one. Okay, it is just single, it's a single opacity, right, which is present down several to almost 1.5 centimeter. So such kind of thing is actually called as a solitary pulmonary nodule. Remember the definition of a solitary pulmonary nodule: any kind of an opacity that is extending from several okay, or any kind of an opacity of size from several to 1.5 centimeters and less than 3 centimeters, and occurring as a single lesion along the lungs is called as a solitary pulmonary nodule, right? And now, how can you actually differentiate between a solitary pulmonary nodule and a mass? Actually, it's the size itself. Okay, now you measure the size, and let us say if it is greater than 3 centimeters, yes, you called it as a mass. Okay, and if it is less than 3 centimeters, you generally call it as a solitary pulmonary nodule itself. Okay, uh, you see, generally, I can tell you one thing. You can not call the Gons complex as a solitary pulmonary nodule. No, generally we don't call it as that way, because the size of the Gons focus actually depends on the amount of the granulomatous reaction that is going on within the lungs. Okay. You cannot call a Gons complex as a solitary pulmonary nodule. Solitary pulmonary nodules are generally because of a condition like tuberculoma, hamartomas, okay, and teratomas and other things like that. Okay, solitary pulmonary nodule generally you call it as pulmonary hamartoma. Hamartoma. Okay, for your knowledge purposes, pulmonary hamartoma is a teratoma that actually shows up popcorn calcifications. Okay, they show up popcorn calcifications. What is the characteristic feature of pulmonary hamartoma? You can say it as popcorn calcifications. Yes, that is a solitary pulmonary nodule, but Gons focus, no, Gons focus is not called as a solitary pulmonary nodule. Now, let us say if you cannot technically prove that the patient has got a tuberculosis, yes, you may call it as a solitary pulmonary nodule. Speaking we can say, what is the confirmatory diagnosis for TB? Can somebody tell me what is the confirmatory diagnosis for TB? What is the confirmatory diagnosis for TB? No. No. It's not tuberculin test. No. It's not tuberculin. No, no, no. Okay. The confirmatory diagnosis for TB is gram staining, acid fast bacilli staining along with the sputum culture. Right? Isolation of the mycobacterium, okay, along with gram staining, acid fast bacilli staining, okay, which we uh, does, that is the confirmatory. But piperacillin tuberculin test, PTT test, or Montus test is a screening test for the people who had primary tuberculosis or secondary tuberculosis. To know who has tuberculosis and who do not have tuberculosis, it's a screening test. But a confirmatory diagnosis for a person who already has the tuberculosis will be made by acid fast bacilli staining along with the sputum culture, right? Okay. Now, so the answer to your question before is that, okay, if I have to evaluate if it is a solitary pulmonary nodule or if it is a tuberculosis thing, okay, now obviously I do the I will obviously do the sputum culture and see if it is TB positive. Now I can define that the solitary pulmonary nodule as a Gons focus. Generally, so we do not actually do it like this. Radiology has actually provided better information. Tuberculosis radiographic features are much more specific. Okay, when we are trying to deal about tuberculosis by the end of this chapter, yes, you will understand how to differentiate and how to confirm tuberculosis. Okay, now here next you see here, you can see there are so many calcifications, all this one all over the lung. You can call them as microgranulomas that obviously are occurring down along the interstitium, right? They are small discrete nodules present all over the right lung. Now you can look here closely. If you can say it, it is a nodular pattern. Okay, it is a nodular pattern, and when compared to the nodules in the previous image what we have seen, this one has got a better opacity. They are looking a little bit much more white. They are looking much more prominent. And how can I define this? Prominent, okay, prominent discrete calcified granuloma like nodules diffused all over the lung fields is a characteristic feature of what? Varicella pneumonia. Or you can technically say that the most of the viral pneumonias will show up as multiple prominent calcified granulomas that are distributed all over the lung spaces. So multiple small calcified granulomas are a characteristic feature of varicella pneumonia. Okay, simple. Right. You see here? Okay. Yeah, I can see. I understand. Now it's okay, I guess. Right. Okay. See here, this one actually shows up as a small prominent calcified granulomas that are distributed all over the lung field. How can I say these are calcification? Because they look a better white than the nodules that I have looked before. Okay, that's how I know that these are calcifications. Now, small, discrete, prominent calcified granulomas distributed all over the lung fields is a characteristic feature of varicella pneumonia. And speaking of which, varicella pneumonia is indeed an interstitial lung disease. Uh, if you have slides open with you, please look also there, right? Okay, while you listen to my voice, please follow the slides. I think it must have been happening because of your internet connection, right? Okay, you have to just give it time to let it buffer, okay? Right? Varicella chickenpox, right? Varicella zoster. Now you can see here interstitial lung disease has got discrete reticular nodular or reticulonodular pattern. They are separated by normally appearing aerated lungs. Okay, normally appearing aerated lungs. And then marginization, yes, they are sharp and usually discrete. Disease may be, yes, focal or diffuse, and there is no air bronchogram pattern present. You see here, these opacities are not as the same opacities and much more thicker than the airspace diseases. No, these are thinner opacities when compared to the airspace disease. So that's the reason we don't have an air bronchogram pattern. So is air bronchogram pattern seen in interstitial lung disease? No. Pneumonias are the ones that are actually presents up with an air bronchogram pattern. Remember, air bronchogram pattern is a commonest feature that is present down in pneumonias. Okay, interstitial lung diseases generally do not have space related problem, which means to say the lungs will have good volume. There is good volume, right? But still, the patient's expiratory capacity is decreased, right? The patient's vital capacity is decreased because why? The connective tissue or the supporting structure of the lungs is actually not letting them completely, expand. So now secondary features also can be present, but usually you remember that no air bronchograms are not present in the interstitial lung disease. Right now, we'll start looking at one of the most specific examples. Okay, we'll start with the interstitial edema. Okay, some of the most important causes of interstitial edema is that you have to remember and look for the patterns of all mixture of all these opacities. Okay, whatever the reticular pattern, nodular pattern, reticulonodular pattern, all of them come in different overlapping mixtures together. So that one is usually one of the most characteristic feature of any kind of an interstitial lung disease. You expect it to look the same way like the in the first image like sarcoidosis, but no, they generally do not happen it that way. Now the first interstitial lung disease we are going to look at is pulmonary interstitial edema. Pulmonary interstitial edema is entirely different from pulmonary alveolar edema. Last time we have seen a kind of a condition which is actually caused and associated with hypertension and congestive heart failure, where it has been showing up a bat wings appearance, if you can remember. That one is a pulmonary alveolar edema. But now this is actually showing a almost the same kind of appearance, but it can actually also happen because of the increased capillary pressure. Okay, it can either be transitive or exudative. Okay, right, before we were looking at the exudative, if it is actually happening down and the fluid is being filled up in the alveoli, we called it as pulmonary alveolar edema. Right now we are able to differentiate between the alveoli and the interstitium. So yes, there here it is a transitive thing, that one is there exudative. So increased capillary pressure in case of congestive heart failure, or increased capillary permeability, which is actually happening in case of allergic reactions, and decreased fluid absorption, or you can also say it as lymphatic, we call it also lymphectasis. Okay, lymphectasis is nothing but blockage of your lymphatic vessels. Okay, and it can be happening because of a metastatic lung disease. So what are the causes of pulmonary interstitial edema? Pulmonary interstitial edema can be happening because of increased capillary pressure or increased capillary permeability, or it can be happening because of decreased fluid absorption, which usually causes lymphectasis. Okay, lymphangectasis, you can call it as. Now, how can we recognize it on a chest radiograph? You can recognize it as a chest radiograph that the first thing is that it will have fluid in the fissures. Remember, there is some or moderate, mild to moderate pleural effusion, especially in the fissures. First radiographic characteristic, how can you actually remember? Fluid in the fissures. And last time somebody was asking, sir, what exactly is a fluid in the fissures? Fluid in the fissure is nothing but your encysted pleural effusion. You can either call it as fluid in the fissures, or you can also call it as encysted pleural effusion. Then there will be peribronchial cuffing. Okay, I will tell you what exactly is this peribronchial cuffing. First, remember the term. It is called as peribronchial cuffing. So from the fluid in the walls of the bronchioles, and then there will be pleural effusions and there will be curly lines, right? Okay. Now you have to understand one thing. If you can remember last time, the pulmonary blood vessels are present within the interstitium. Yes or no? The pulmonary blood vessels are present within the lung interstitium. Yes, right? Okay. Now, so now you have to understand from these radiographic features what you actually look here. If there is an increased capillary pressure within that blood vessels, okay, there will be the transitive fluid. Now, if I see the opacities within the interstitium and a patient suffering from congestive heart failure, now can you tell me how can you actually recognize this patient within the symptoms, or how can you actually understand from this? Okay, if I say that there is increased capillary pressure, I can see the opacities within the interstitium, right? That is what I say. I can see something around like reticular pattern. If I am looking at this reticular pattern, what this one also indicates, it indicates that the alveoli are still free. So any kind of moderate hypertension people will eventually start developing and progress down into the alveolar edema later on. Okay. So which means to say moderate grade hypertension or grade 2 hypertension people will generally present up with that interstitial edema. Long-standing patients with a grade 3 hypertension and a chronic presentation will usually come up down with the fluids that are present down within the alveoli. Now, who will have more respiratory distress? Is it the interstitial edema guy or is it the alveolar edema guy who will have most distress? Alveolar guy is going to have the more respiratory distress when compared to the interstitium. Exactly, right? Shubham, why do you think it is interstitium? Now, this is one immediately it equally directly presents up with a hint that how can we actually differentiate between pulmonary alveolar edema and interstitial edema. Yes, fluid is present there, and usually that one, the interstitial edema generally will not show up as generally they don't do not show up as a bad wings appearance, but you can no blood vessels compressed doesn't necessarily mean to say it is interstitial edema. Okay, no, I'm saying who will have blood vessels compressed is a thing that is related to vasodilatation and vasoconstriction, related to BP, not related to oxygenation and ventilation. Yes or no, Shubham? My question was which of the patient will have more, okay, which of the patients will have more respiratory distress? Is it the alveolar edema guy or is it the interstitial edema guy? It will obviously be the alveolar edema guy who will show up with respiratory distress, right? Did you understand now what I have been talking about? Okay, now moving down into more, you can see here now this is actually the progression. So first fluid in the fissures, mild grade fluid in the fissures, then there is a peribronchial cuffing, then mild grade pleural effusions, and then Kerley B line start. Now immediately after this they immediately progress down. If there is still more increased capillary permeability, there will be more increased capillary pressure. Now slowly the fluid is going to diffuse down into the alveoli and fill up the alveoli, giving out a pattern called as bat wings appearance. So which means to say, which is the first thing that is actually happening? Pulmonary interstitial edema is the first thing that is actually happening. Look closely. We say that this one actually shows up as attenuation of the pulmonary interstitial markings. You see here, all the interstitium are shown up as irregular opacities, thickened opacities that are showing up here in the black circle. And when you look at the bases, last time also I was talking, when we look at the bases, you see here small lines, horizontal lines that are coming down at the base of the lungs in the periphery. So we call them as my camera is off. Why? Okay, it is within the screen itself. Screen itself. Can you see now? Right. Okay. Now you see here, it's the it's the same thing here. You look closely, if you look closely, there is an attenuated white opacities, which obviously shows that it is coming out from the interstitium. And along the base, if you look closely, there are horizontal lines that are coming, projecting towards the center along the periphery, and they are present on the base. And such kind of lines are actually called as Kerley B lines. Okay, these are Kerley B lines and interstitial. So what exactly this pattern is? This pattern is interstitial edema, pulmonary interstitial edema. Okay, right? Man, I don't know why you guys are having a lot of technical problems today, right? Now, how can actually these patients present up with? These patients generally present up with rails, even though the chest radiograph demonstrates considerable pulmonary interstitial edema, because almost all the fluid in the interstitium is present within the interstitium itself rather than presenting in the airspace. If the No, the description of that black spot is actually, see, the description of that black spot is nothing but your attenuation of pulmonary markings. Attenuation of pulmonary markings in the sense, okay, they are not looking very fair enough. Okay, those reticulations are not looking very fair enough, which obviously means to say it is actually looking down as an inhomogeneous reticulation. Okay, right? You see here, inhomogeneous. Did you get it, Benedict, now? It is actually called as attenuation of pulmonary interstitial markings, which means to say they are not particularly very prominent. Okay, right? Right. So that's the reason we call it as attenuation. Okay, nice. Now, how actually this patient presents? The patient presents up with rails because all the fluid, wherever that is present, it is present down within the interstitium itself. If it is present down in the air spaces, we actually will be getting down as the crackles, or we will be getting down as the bronchial sounds. But here you see they are looking rails. You have to try to differentiate between crackles, rails, tracheal sounds and bronchial sounds, which you will learn in your diagnostics class when actually the teacher teaches you about these lung sounds. Try to pay attention. Yes, the pulmonary interstitial edema guys generally presents up with rails, and with appropriate therapy, these rails clears rapidly within 48 hours. And if it is not cleared within 48 hours, yes, I am going to think about some other diseases like tuberculosis, sarcoidosis, etc. Right. Now we'll talk about another thing that is actually called as interstitial pneumonias. If you can actually understand with the name itself, it is something somewhat contradictory. I mean to say, the way we understand. Last time we were saying, okay, pneumonia is an airspace disease, and now we are talking about the pneumonia that is happening in the interstitium, right? So it is somewhat contradictory and somewhat, that causes a confusion. Actually, you have to understand it is a pneumonic disease with a pneumonic pattern along with an interstitial component that is associated with it. Okay? You have to understand that the etiological factor of these pneumonias here is entirely different from the pneumonias what you are talking about there. It's an atypical pneumonia here, and where that one is a typical pneumonia, bacterial pneumonia there. Okay, pneumonia is nothing but something that has been filled up within the air spaces. But you have to understand, for any kind of filling into the air spaces, the direct way to come down it is from the bronchuses. But there is also another route which is also happening from the interstitium as well. And I can say most of the times any kind of desquamative interstitial diseases, okay, and proliferative interstitial diseases, allergic inflammatory diseases, all of them, allergic, inflammatory, proliferative, desquamative interstitial lung diseases, eosinophilic granulomatosis, okay, eosinophilic granulomatosis, okay, eosinophilic pneumocystis, pneumocoinosis, okay, pneumocystis carinii, all such kind of a diseases generally, they present up with a pattern called as interstitial pneumonic pattern. Okay, what we have, there are three patterns here. Usual interstitial pneumonic pattern, okay, which is the most common form. Then we have the desquamative interstitial pneumonic pattern, which is called as the DIP. Then there is called as a lipoid interstitial pneumonic pattern, LIP. So there are three patterns of interstitial pneumonias: usual interstitial pneumonia, desquamative interstitial pneumonia, DIP, and then lipoid interstitial pneumonia, LIP, right? So first we'll talk about the UIP, usual interstitial pneumonia. uh, okay, we'll do one thing. Let us have a break here. Let us have a break here, and then I will call back once again. Okay, right? I will call back once again. Right? Let us. I will end up the call here. Let us have a break now. Okay, right. Benedict was asking a very interesting question. Benedict was saying, is it something that, okay, if all the fluid or the edema has been displaced down into the lung interstitium, but not the alveolar space, do you mean to say that the dyspnea is actually happening because of the edema that is being pushing the alveoli? Yes, the answer lies in your question itself. Yes, the interstitium has been having a transudatory fluid which increases or restricts the pressure along the interstitium, which restricts the alveoli to expand. So, which obviously means to say that dyspnea is actually happening because of this counteractive pressure itself, right? So, Benedict, is your answer clear now? Right? I think it's Moxie Doxy, somebody who has asked this question. I think I'm guessing it's Benedict itself. Right? Did your answer get clear now? Please respond. Who asked that question? I guess it's Moxie Doxy. Moxifloxacin, doxycycline, whatever that name suggests. Right. So that's it. I need that guy's response, and except for that guy, everybody is responding. Huh? Right. I guess he's not in the group itself. Okay. Let's try to continue. Okay. Yeah, of course I'm recording the class. Of course I'm recording the class, but it doesn't necessarily mean to say that you have to, keep yourself so disoriented, right? Because I guess you are the one who is making a lot of noise whenever I open up the mic. Clara. Yeah, I'm recording the class, but it doesn't necessarily mean to say that you have to disorient yourself and move away from the class. Right? Okay. So, can everybody see the slides? Man, it's late for everybody too, dear. Okay. Yeah, I know. I will complete in 45 minutes, okay? Right. I know. Right. Okay. So interstitial pneumonia, we are talking about usual interstitial pneumonia, is sometimes also known as idiopathic interstitial fibrosis. The name itself suggests that it has no kind of, any kind of a particular etiological factor that you can find out, and it happens in the interstitium, and it causes a progressive reaction called as fibrosis. So it is called as idiopathic interstitial fibrosis. And now it is always common in uh, older men and has association that is related with cigarette smoking and also gastric esophageal reflux disease. Rather than we getting down into the pathophysiological mechanism, we will try to understand what exactly is the pattern and how it shows up on a chest radiograph. So the thing is that you have to understand usual interstitial pneumonia generally presents up with a fine reticular pattern. Okay, particularly along the lung bases. So it is along the lung base and the pattern is reticular and it is fine. Okay, and then later on as the disease progresses, they become coarser and then they get down into a pattern, a typical appearance, which is the characteristic for all kinds of interstitial lung diseases, remember, which is actually called as honeycombing. Okay, so honeycombing pattern or honeycombing lung is a characteristic feature of interstitial lung disease, and to be particular you have to say it is usually in usual interstitial pneumonia, UIP. Honeycombing is a characteristic feature that is seen in interstitial lung diseases. And how can you actually define that one? You can actually define that there is a fine reticular pattern that is seen along the lung bases. Okay, And you can also understand if it, since it is actually happening in the interstitium, it means to say there will be a progressive volume loss. Coarser means to say thick, thick, thick. Okay, coarse means to say thick, thick, thin. Okay, coarse, thick. Right. Now, the thing is that how can we actually make the how can we actually make the diagnosis? Like what I was telling before, HRCT is the investigation of choice. Okay, or we can also say it is a gold standard. Okay, it's a gold standard test, uh, and the diagnosis is made on CT. And what you actually see on CT is nothing but your honeycombing. Then you have traction bronchiectasis. Okay, I will explain this one, but just first remember the name. It's called as traction bronchiectasis. Traction traction bronchiectasis means to say it is traction bronchiectasis means to say the bronchuses are there. The bronchuses are permanently dilated. That's what bronchiectasis is. And now they have been pulled. Traction means to say pulling of the bronchuses that are permanently dilated. So that is traction bronchiectasis. And then we have a ground glass opacities. Remember, ground glass opacities. I'll show you the picture. You will understand what exactly is a ground glass. Ground glass opacity, in the sense, you also call them as GGO. Okay, G, G, and O. Okay, ground glass opacities. So what exactly is a ground glass? Ground glass is that when you try to break down the glass, you have certain kind of an appearance to the broken pieces. Okay, ground glass. Okay, let me share the picture with you, how actually it looks like is ground glass. It is a typical pattern that is always seen in every interstitial lung disease. Okay, look at this image I have just shared there. Okay, and then when you look closer, what actually the ground glass, in the sense, okay, if you have polished a glass, it actually looks very, you know, like faded away. Okay, something like faded away. When you see the base, let me share that picture also with you so that you can actually understand what I have been mentioning about here. Okay, look at your two images. Sorry. So can everybody see the screen, what I have been sharing now? Right? Okay. This is the ground glass appearance. Okay, you see here, this is the ground glass appearance. They look so hazy. They look so bright. And what exactly is a ground glass is this one. Ground glass, you see here, when compared to the completely transparent area of the glass that is present above, and you see here, when you look at below, it looks so white and hazy, right? When compared to the transparent area that is present. So this is actually called as a ground glass, a glass that has been polished with the sandpaper, how it looks down. Or simply speaking, whenever you break a glass, the edges of the glass actually appear as a ground glass itself. So this kind of pattern is actually called as a ground glass opacity. So this is very typical presentation for any kind of usual interstitial pneumonia, honeycombings, traction bronchiectasis, and ground glass opacities at the bases are a typical radiographic features of interstitial pneumonias. And best example is idiopathic pulmonary fibrosis. You call it as IPF, is considered as an end-stage disease along the spectrum of these interstitial pneumonias. As the disease progresses, a typical finding which you see here as a chronic interstitial lung disease, what we can find? We can find honeycombing, traction bronchiectasis, and ground glass opacities. As simple as that. Now you look here at this image, you look here at the lung peripheries. In the lung peripheries, okay, where these white arrows are being marked, you see here, when you look close enough, they are so opaque. And you see here the This one small black spaces that you look around this space are the bronchuses, and there is interstitial thickening, and they look as an opacity there. And at the same point of time, you look here, the lung space that has been present along the lateral segment of the right middle lobe, and you can also say that in the superior segment of the left lingular lobe, you can actually see that the problem is present down in the peripheries, and there is a traction, and there is a progressive, and there is a predominant or significant loss of lung space. Volume has been reduced. Okay, volume has been reduced, and you can see here this is actually called as traction bronchiectasis. Along a permanently dilated bronchuses, you can actually see the space has been reduced. And you look here closer enough, here there is a dotted line, and you can see here there is a lining along the bronchuses. This actually indicates that these bronchuses have been permanently dilated. Okay, and you see here at the surrounding area itself, there is some of the ground glass opacities that are present here, and you see here bronchuses that are present so closer, and they look like if that has been eaten by some kind of an insect. So such kind also can be called as a moth eaten appearance, or you can also call it as honeycombing appearance. Okay, honeycombing is a characteristic feature. You see here the white circle actually shows up that there is representing fibrosis. There is a lot of fibrosis that is present. When you look the same person onto the CT, you can actually see this is the honeycombing, and you can see the traction bronchiectasis and traction bronchiectasis here, right? And you can also see, look along the peripheries, there is a similar ground glass appearance. So these characteristic features on a CT usually suggest this person is an usual interstitial pneumonia, right? Also, the same thing you see here, the white dotted line, you see here, this white dotted line is the thickened bronchial walls, right? Thickened bronchial walls. You can also call this one as tram tracking. Okay, remember, you call this one as tram tracking, or you can also call this as railroad sign. Okay, railroad sign or tram tracking appearance. Okay, tram tracking, tram tracking appearance, or railroad sign. Okay, right? So permanently dilated bronchuses along with the thickened bronchuses actually show such kind of a appearance that is actually called as traction bronchiectasis. Okay, traction bronchiectasis. It is a characteristic feature of any kind of COPD, but particularly in COPD, we generally do not see these ground glass appearances and this honeycombing appearance. So how can we actually differentiate bronchiectasis from usual interstitial pneumonias? Is that ground glass opacities and honeycombings are not there, but there is only thickened bronchial walls. So what is a characteristic feature of bronchiectasis? Tram tracking sign or railroad sign. Okay, that's what it is. Right. Now the next thing we are going to look about is the bronchogenic carcinoma. Right, just this is the chapter there, and then after that we will try to close off our class. Right, bronchogenic carcinoma has got 4 types. It has got adenocarcinoma. Okay, then we have got squamous cell carcinoma. Remember, squamous cell carcinoma, small cell carcinoma, and large cell carcinoma. There are 4 types of 4 types of bronchogenic carcinoma. Any of the carcinoma that is occurring along the bronchuses or having an etiological relation down to the bronchus. There are 4 major types of bronchogenic carcinoma. They are adenocarcinoma, squamous cell carcinoma, small cell carcinoma, and large cell carcinoma. If you can remember what you read in pathology, they have got different kinds of pathological presentations. Everyone has got its own pathophysiological mechanisms, and everyone has got different kinds of features on the pathological sections. The same way, they have got different particular patterns over the radiographs itself. Now, if any kind of adenocarcinoma, if it is occurring down as a single focus, if it is occurring down as a single small nodule, it is called as a solitary peripheral pulmonary nodule. So, solitary pulmonary nodule generally indicates what kind of disease? It is an adenocarcinoma. Before, person was asking, okay, can we differentiate between a Gons focus and a pulmonary nodule? Unless and otherwise proved, a solitary pulmonary nodule generally indicates it is a cancerous tissue. It is a neoplasm. Okay. I can see a solitary pulmonary nodule, a small opacity that is present down in a single part of a lung. And it is something around like 1.5 centimeters to 3 centimeters. Now it is technically called, and it can be diagnosed mostly as an adenocarcinoma, which has to be analyzed. Now a question: what is the confirmatory diagnosis for a solitary, for a confirmatory diagnosis for a lung carcinoma? Confirmatory diagnosis for a lung carcinoma. Okay, you can call it as punch biopsy, or you can also call it as FNAC, right? FNAC. Don't try to forget the complete name. It is called as fine needle aspiration cytology or biopsy. Okay, it is a pathological study. Pathological studies are the gold standard for the confirmation of lung carcinoma, right? Now, why I actually fine needle aspiration cytology and punch biopsy. Okay, these are the confirmatory studies. Now, so generally, this is an invasive technique, biopsy, fine needle aspiration cytology, or an invasive techniques. But before we can also do a staging or a kind of analysis, preliminary analysis on a CT scan itself. Okay, now let us try to see what exactly are the features, right? Now, what actually happens on conventional radiographs, you will have a sharply marginated, okay, which is entirely different from an airspace disease, producing relatively a clear demarcation between the nodule and the surrounding normal lung tissue. You have to understand, before, usual interstitial pneumonias generally are involving all over the interstitium. Pneumonias are involving all over the lobes and our entire segments. Now they do not have clear margins. Usual pneumonias actually only until the interstitium that has been involved, yes, they show clear margins. But how can you actually differentiate it from a bronchogenic carcinoma? You can differentiate it by a sharply margin, right? And you have to remember there is a very particular sign on a CT which is actually called as a speculation. Okay, speculatory sign. Okay, speculatory sign. Okay, speculatory sign or pleural tail sign or satellite lesion. Okay, you call them as a speculatory sign or pleural tail sign or a satellite lesion, which is a characteristic feature of bronchogenic carcinoma. Do not ever forget this kind of radiographic feature. Speculations or irregularities around the lung nodule are present down in CT scans, which is confirmatory of a bronchogenic carcinoma. Let us look at the image. When you look at close image, you see here there is an well-defined, sharp, irregular border of a well demarcated mass. Here, you see here, there is a mass. How can I say this is a mass, but it is not a nodule? Because it is greater than 3 centimeters. It is present in the upper lobe, right? And now it has got a superior lateral border, okay, which is slightly indistinct when compared to the lower border, which means to say this superior lateral border is attached to the interstitium and attached to the pulmonary spaces, sorry, plural layers, okay. Plural tail sign actually indicates, okay, plural tail sign actually indicates, speculation actually indicates that there have been fibromatous extensions from the mass to the pleural layers. So it is an attachment. What is a speculation? It is an attachment to the pleural layers, and it is happening around the superior lateral borders of the mass. And that one is actually called as a adenocarcinoma. And you can also see that this is most of these diseases are malignant and they have a lymphogenic spread, lymphatic spread. So that's the reason you can also see that there is a paratracheal lymphadenopathy. Okay, you cannot generally appreciate that lymphadenopathies on a conventional radiograph. Okay, paratracheal lymphadenopathies can also be seen. You have to understand that there are 6 groups of lymph nodes along the hilum, okay, all over the lymphatic tissues along the hilum, but generally we cannot appreciate them on a conventional radiograph on an X-ray like this. So confirmatory diagnosis can also be made upon a CT, okay. CT scan generally what they show, it shows up a well defined presence of a mass and demonstration of paratracheal and right hilar adenopathy, and indicates that it is generally an adenocarcinoma. Now let me give you much more explanation that is related to the tuberculosis. If these both areas, okay, if these both areas are calcified, okay, if these both areas are calcified, they are generally called as a Ranke's complex or a primary complex in a tuberculosis patient. This one actually does not look like the calcification, right? It does not look as bright or as opaque as calcification. So either by the density itself, I can understand this is not a tuberculosis lesion. Even though it is occurring down in the apex of the right lung, I generally do not say this is as a Gons focus, because there is a difference between granulomatous reaction, liquefactive necrosis, or the caseous necrosis that is happening in a tuberculosis patient when when compared to the uh, people with adenocarcinoma. Did you understand the question what you asked before? How can I again differentiate it between a Gons focus and an adenocarcinoma? How can I differentiate it? It does not look up, the lesion, the density does not appear as calcified as in tuberculosis. The lesion usually appears with no calcification, but there is a very heterogeneous. Man, is there a problem with these guys? I guess I don't know. Okay, right. Now, what we actually did was the mass was biopsied, and this was confirmed as the primary adenocarcinoma of the lung. And yes, it usually presents down, the adenocarcinoma usually presents as a peripheral nodule. So how can I remember the characteristic features? Spiculations or pleural tail sign along with a well-defined marginated, yes, in Gons focus, yes, there can be a calcification, and the type of necrosis that is actually happening there is liquefaction and caseous necrosis, but that is not actually happening in adenocarcinoma. If you can also follow up with the pathology, there is a caseous necrosis and the liquefactor necrosis depending upon the stage of the tuberculosis that is happening, and that kind of nodule is much more heterogeneous, and adenocarcinoma is much more homogeneous. Right, Benedict? Is that clear now? Gons focus, yes. Yeah, adenocarcinoma, there won't be any kind of a calcification, but calcifications generally, yes, as the disease progresses, some of the lung cancers also progress down into calcification, but usually it is not this one. It is actually squamous cell carcinoma with a cavitation. Okay, we'll talk because all of them come belong down to the same group. We will talk about it. Okay, look here. Now, there is another thing that is actually called as a metastasis to the lung. You can see here, there is, if it is actually happening along the blood vessels, we call it as a hematogenous metastasis. Hematogenous metastasis actually appears down as small, small nodules that are distributed bilaterally all over the lungs, and they look up as bigger, bigger nodules, right? They are bigger nodules. And now, if it is actually happening down, and hematogenous spread usually happens from the periphery to the center, because the blood vessels, wherever the blood vessels usually, any kind of a lesion that is involved with the blood vessel will be showing up down along the bases and from the periphery to the center. Right, exactly. You will see. We will try to look at that. Uh, TB generally it is not actually like metal thing, but they will be more heterogeneous and well demarcated. We will talk. They will have a capsule. Adenocarcinoma generally will not have a capsule. We'll talk about it. Okay. The last topic in this one is TB itself, and then we will try to differentiate all three diseases. Okay, don't worry. I will explain about that one. And then lymphatic spread is generally present within the center because most of the lymph nodes are present along the hilum. So generally, you can see a lymphadenopathy here, and you usually when there is a lymphadenopathy that is associated with a nodule that is present along any part of the lung, usually indicates it is some kind of a metastatic lung disease, right? And then there is a direct extension down into the surrounding soft tissues, or it might be connected down to the pleural surfaces. It is actually called as a pleural sign, and they appear down as multiple lesions, which are actually called as satellite lesions. Okay, they are freely floating in the lungs, like, okay. That's the reason they are called as satellite lesions. So pleural tail sign and uh, speculatory sign or a satellite lesions are generally any kind of opacity presenting in with that kind of pattern usually indicates it belongs to bronchogenic carcinoma, right? Hematogenous spread, yes, they are larger, and they can also be called as cannon ball metastasis. Okay, do not ever forget, this is a very, very classical presentation. It is actually called as cannon ball metastasis. I will show you the picture, you will understand it. Cannon ball metastasis occurs in case of hematogenously spread metastatic diseases that are secondary to breast cancer, colorectal cancer, renal cell cancer, bladder cancer, testicular cancer, head and neck carcinoma, soft tissue sarcomas, and malignant melanoma. Out of which, in males, it is the testicular cancer which usually causes this cannon ball metastasis, and in females it is either the breast cancer, right, or the soft tissue sarcomas. Okay, males testicular cancers are the usually the most common cause of presentation, and in females breast cancer and soft tissue sarcomas are the most common presentations. And cannon ball metastasis is related to hematogenous spread. Okay, they appear down as two or more nodules which generally achieve a large size. Okay, let us try to look at this image. You see here, there are bigger opacities that are diffusely present, and you can see here when you look closely here, right? When you look closely here, there is an attachment of this thing to the surrounding structure. So this is what the speculation usually means. You see here, everywhere each bronchosis has been associated with this one, and there is at the end there is a well defined with a white opacity that is present, and it is diffusely present. There are so many multiple lesions that usually look the same, and such kind of lesions are actually called as cannon ball metastatic lesions. Well, this patient is generally happening. We came to know that this patient is suffering from a colon cancer, but generally multiple nodules, okay, multiple nodules, which has got connections with the surrounding soft tissues. You see here, when you look at these lesions closely, it has got a direct connection to the pleura. You see here, that is what the speculation on the pleural tile is. Okay, so such kind of a thing usually is called as a cannonball metastasis, and the most common reason in males is testicular cancer, in females it's breast cancer, right? The second one is the lymphatic spread, and generally they are happening down, and which are entirely different from the blood-borne diseases or the pulmonary capillaries. That is what the hematogenous spread looks like, but this one is actually happening down through the invasion to the adjacent lymphatics. Okay, and now usually what they cause is that they obstruct the lymphatics, usually around the hilar region, and they cause a retrograde dissemination through the lymphatics. Okay, I will show you what exactly is this retrograde dissemination, right? They are retrograde dissemination. So now what, the lymphationic spread, and there is an obstruction to the central lymphatics. So which means to say the lymphatic chain is involved in it. Now you tell me, in pathology, if you have learned what exactly, how can we usually make any kind of a staging of a metastatic cancer? What is the common methodology that we use for staging of a metastatic cancer? What do we do? Staging of a metastatic cancer is done by TNM staging, right? TNM staging usually says that there is a tumor. Okay, there is a tumor. Let us say there is a 3.5 centimeters tumor that is present down in the apex of the right lung. Then there is also associated with nodule. Nodule is nothing but your lymph node. Okay, there is nothing but your lymph node. Okay, then the nodule is that there is a lymph nodes that are present. Okay, right hilar lymphadenopathy is present, or let us say that okay, all the pretracheal lymph nodes or the paratracheal lymph nodes, all the metastatic, all the mediastinal lymph nodes or the axillary lymph nodes have been increased. There is a lymphadenopathy, predominant lymphadenopathy of the axillary lymph nodes, predominant lymphadenopathy of the pretracheal lymph nodes, and then there is a metastasis, which means to say the primary lesion is either present down in the testes, and now it has been metastasized, distance metastasized into the lungs. So now we actually use that TNM staging. So generally speaking, what you have learned in the TNM staging is usually done on a radiographic image. Okay, TNM staging, what you learned in pathology, is generally done on through radiology. Radiology is the investigation, that is the module, that is the medium that is used for doing this TNM staging of this one. Okay, generally we call this one as a stage 1A, stage 2B, stage 3B, something like that. Okay, uh, we will not be dealing about the TNM staging here in this class in the undergraduate levels, but generally you remember that yes, confirmatory diagnosis, analysis of the metastasis, analysis of the progression of the disease can be done by TNM staging, but the confirmatory diagnosis of the lung cancer is usually done by a punch biopsy, right, or fine needle site aspiration cytology, FNAC, right? Okay. Now, how can actually they look like? They actually resemble pulmonary interstitial edema, okay? But they will be localized to a single segment where the congestive heart failure is diffuse, but this lymphogenic spread is generally localized to a single segment or involves only one side of the lung. So now how can I differentiate between congestive heart failure and a lymphogenic spread metastasis? I can say that it is congestive heart failure or pulmonary interstitial edema is generally bilateral, right? And it is not local, it is diffuse. You can see all over the lungs. It is both the lungs are involved, but lymphogenic spread, wherever the mass is present, that is the place, that segment is involved, that lung is involved. And along with them, yes, sometimes I can also see the curly lines. Yes, Kerley lines, what the lines we actually see here are Kerley A lines. Okay, we will talk about that, are Kerley C lines. That is there. This kind of explanation to Kerley lines is present down in your practical sessions. Okay, try to learn about the Kerley lines that is present in the practical session. Look at those slides. Okay, I will not teach them now. We will teach about them more in cardiovascular system. But remember, they will be having Kerley A lines and Kerley C lines. And then yes, you will have encysted pleural effusions, and you will also have the pleural effusions along the cardiophrenic recesses, costophrenic recesses. Okay, CPS. And then generally they are related to breast, lung, stomach, pancreatic, and infrequently prostate carcinoma. Yes, what are the most common diseases? What are the reasons for metastasis? This is an important question. What are the pathologies that are associated for metastasis of the lungs? Okay, what are the secondary, what are the primary diseases that for the metastasis of the lung? Okay, what are they? Breast cancer, stomach cancer, pancreatic cancer, prostate cancer, soft tissue cancer, malignant melanoma are the common ones. What are the characteristic features? Characteristic features are localized lung segmental, uh, you know, interstitial like opacities along with Kerley lines and encysted pleural effusions and pleural effusions along the costophrenic recesses. Right? You look here, the same thing. It is very typical here. There is a lymphadenopathy. See, this one is a lymphadenopathy. There is a lymphadenopathy. There is a lymphadenopathy, and you see here the black dotted lines. These one are called as the septal lines, which actually indicates that there has been a connection down to the surrounding soft tissues, right? And the septum is shrinked. Okay, they are the whole surrounding septum has been shrinked, right? And then it actually indicates that it is actually happening because of a lymphatic spread of a bronchogenic carcinoma. Okay, this is present down in the right lung, apex of the right lung. Okay, this is the posterior apical segment. Okay, right? And the solid white arrow are the interstitial markings. You see here, there is a reticular pattern that is present, and this is the thickening of the surrounding septa, and there is a bronchus in between. And you see here, then there is a lymphadenopathy, a small lymphadenopathy. You look here, if you have observed this, we are not looking them in a lung window, we are looking them in the lung window. Lymphadenopathy is generally analyzed in a mediastinal window, but usually you see here this space between the aorta and the trachea in between, this one is generally not this spacious, but the space has been increased in between. By this I can understand, yes, there could be a lymphadenopathy. So which means to say I'm talking about the hilar and the mediastinal lymph nodes have been enlarged. And generally speaking, you see here there is no tumor here, but generally the tumor could have been present in the upper regions or the lower regions here. But generally this one usually indicates the primary lesion is not present here inside the lung. The primary lesion is present somewhere in the other part. So if I see a pattern like this, yes, it usually indicates that has been a metastasis inside the lung, but the primary lesion is not inside the lung. Okay, the primary lesion is present within the some other tissues. Okay, generally say if this is okay, I can see this is a male because there is no breast shadow. So most probably we can associate this person could be having a prostate cancer or could be having a testicular cancer, usually seminoma, right? So that is the lymphogenic spread. uh, then there will be direct extension because of the pleura, and there is a resistance to the spread of the malignancy due to the direct violation of its layers. Okay, direct extension is not seen because it cannot go over the pleura. If it is an adenocarcinoma, if it is a primary lung cancer, yes, they can invade the pleura and they can go into the surrounding structures. But it is a metastatic disease, no, they do not invade the pleura. They just can have connection, but they have extensions to that one. And now what you actually call is a direct, what actually happens here is a localized subpleural mass in a lung, and they can also frequently invade the adjacent rib. Okay, And such kind of a disease, what you actually talk about here is a very, very particular and interesting disease, which is called as Lamb disease. Okay, Lamb disease, lymphangioma myomatosis. Okay, lymphangioma myomatosis. It is a Lamb. It's called as Lamb disease, and that one usually shows up a invasion down into the adjacent ribs, along with the pleural spread. Okay, generally direct extension is least common form, but still it can happen, right? You look here in this image, I'm looking down at the CT image in a bone window here. I can see here there is a well-defined mass with a hypodense layer, hypodensity in between. And you see here when I'm looking at the ribs, the rib is completely destroyed. And then there is a direct connection of this tissue into the surrounding soft tissue here, right? You see the lesion has been spread from lung to the outside into the soft tissue along this layer here itself. So this one generally indicates that there is a direct invasion of this lung cancer to the surrounding soft tissues. Okay, right? And now they are not actually present here, and sometimes, usually, that is what we have to learn about the lung cancer itself. We are not going to try to learn about the differentiation between the small cell cancer, large cell cancer. We will have a separate class for the carcinoma of the lung, but generally you have to remember these are the basic features. Okay, the take home message from this class is something that is you have to remember three types of typical patterns of the interstitial lung diseases. The first one is reticular pattern, nodular pattern, and reticulonodular pattern. Then we are going to learn about the interstitial pneumonias. There are four kinds of interstitial pneumonias: usual interstitial pneumonias, idiopathic pulmonary fibrosis, right, and inflammatory and granulomatous and eosinophilic diseases. Okay, usual interstitial. Okay, let me recall back once again for you here. Usual interstitial pneumonia, desquamative interstitial pneumonia, and lipoid interstitial pneumonia. And idiopathic interstitial pneumonia is the progressive form of all of these diseases, right? And they will actually show up a honeycombing pattern, traction bronchiectasis, and ground glass opacities. Remember what is a ground glass opacity. Remember what is a honeycombing. Remember what is a traction bronchiectasis. Okay, you will be having picture-based questions in the MCQs for this one. So you have to remember these images, right? And then you will be talking about bronchogenic carcinoma, types of bronchogenic carcinoma. Try to learn about the definition of a solitary pulmonary nodule, differentiation between a mass and a nodule, right? Then we have to know what exactly is a satellite lesion, cannonball metastasis, speculatory sign, or a pleural tail sign. That is what we are going to remember here. And then what is the confirmatory diagnosis or the gold standard tests that are associated with any kind of carcinoma of the lung, or you have to also see what are the different types of metastasis of the lung diseases. Okay, metastasis of the lung diseases. So that are the important questions. This is a very, very important chapter. Do not ignore the pictures here. Do not ignore the lines that have been bold, right? There can be a lot of MCQs, lot of fill in the blanks, and usually speaking, there will be an essay question. An essay question of 10 marks usually comes down from this chapter. Do not ever ignore this chapter. This is a very important chapter. Okay, all the respiratory system is a very, very important chapter. You will have a case study from